everyone. It looks like we're at just at 5:30 right now, so we will go ahead and get started. First off, I would like to thank you all so much for joining us and spending this part of your evening learning about risk assessment and prevention. And just a few housekeeping items first. You are all muted, so we can't hear verbally any comments or questions. If you do have any questions, please type those into the Q&A box on the right-hand side of your screen. And you may also need to escape out of full screen mode to see that box. At the end of the presentation, we will have about 10 minutes to answer questions. If we don't get to them all, we will be replying to those throughout the remainder of the week. And last but not least, the webinar will be recorded. You will be sent a follow-up email with the link so you can view it at any time, or you can share it with colleagues if you would like. So with that, I would like to go ahead and introduce Dr. Kim Kutsch, CEO and founder of Oral Biotech, manufacturers of the CariFree system. Dr. Kutsch has been successfully practicing dentistry for over 30 years and still practices 2 days a week here in Albany, Oregon. He has an incredible passion for what he does, and his vision to create effective Canberra protocols continues to drive his research to improve caries diagnosis and treatment. So, Dr. Kutsch, I will turn it over to you.
Thank you, and welcome everybody tonight to the webinar. I'm really excited. This is kind of a different webinar for us, different than a lot of things that we've taught in the past, but I am very excited, and I have to tell you that I hear you loud and clearly. We have hundreds of people signed up for this webinar tonight, so I'm beginning to identify that what everybody really needs to see is cases, how you actually implement this. We can talk about the theories, we can talk about the scientific research and the evidence, and we can go on and on and on about that, but what everybody really needs to know is how to deal with these patients. And so I put together tonight, I think you'll find this interesting, a number of cases that I've treated. And really, this is, in my mind, the first part of maybe a 3 or 4-part series. I'm going to go into just risk assessment and diagnosis tonight to look at these cases, because this is one of the trickiest part of care, is really getting down to what is causing the disease for each individual patient. Once you get to that point, then you can direct your treatment strategy specifically or uniquely for that patient. But we really need to get started with the diagnosis aspect. And so that's what I really want to go through some cases tonight with you, show you, just some variations of different things you're probably going to see on patients in your own practice, and hopefully you can relate to some of these. And I'll share some data with you also that I've collected on using the system in my practice. And then additional webinars will get into how do you stage the actual treatment, what specific recommendations do we have. We'll talk about that a little bit tonight, but I plan on going that in more depth in the next couple of series. And also I want to get into wellness coaching and really help you develop the verbal skills that are required to manage these patients through this whole process. Well, it is, how many of you ever see patients like this, but when you're treating patients like this, you're going to end up seeing more of them, particularly if you have some success with them. We have an epidemic of decay in the United States right now, in my opinion, and it's getting worse. It's getting worse in our 5 age children. It's getting worse in our senior patients with xerostomia. But this young man came to see me a few years ago, and he presents with a serious caries disease. And I went through my entire normal call. I did a consultation with him. I explained everything to him. I did everything that I normally do. And so you've probably been frustrated by patients like this. But he left my office, and I didn't see him for 1 year. And he came back 1 year later, and he looked like this. Now, and see, I'm actually working on a tray. I am scrambling to try and save his lower teeth for him. The upper teeth are beyond hope. And so I didn't reach out to him, right? Somehow I didn't connect with him in terms of management and treatment of this disease. And the process itself, here he is a couple years later. We managed to save all of his lower teeth. And, of course, now he has an upper denture for life. And at some point in time, we'll look at implants or something. But being able to take that patient and be successful with them, I would think that in a lot of practices he would be in full dentures. Had I had better verbal skills, maybe at the time, I like to think that he would still have all of his teeth. So I really want to go through, this is, if you can avoid kind of result on a patient like that, rendering them edentulous as a result of this disease, that's really my goal here. And the problem we've got with Canberra or Caries management is it's presented, I think, in too complicated of a manner, and I even, give that. It just presented it as a complicated process, and so I think a lot of people get frustrated, they get lost, they get confused, and they give up. Quite frankly, the practices, I don't have time for this. I don't know what to do next. It's too confusing. I don't understand it. And so I thought it would be really helpful. If we sit down and look at a roadmap, I think in my mind, for most people on this webinar tonight, you're to Canberra, and if I could describe it as a road, it would look like this to you. And so I really want to try and simplify that for you. One of the problems that we have that I've identified in the last year, and this was a really good paper that was published a year ago in Britain, but look at scientific research and academia, we look at cross-sections of populations as we look at our evidence. So we take the evidence of large populations of people, and we look at the statistics, and then we take that evidence, and then we want to apply it to our practices. We're encouraged to, we create protocols, we get recommendations from the Council on Scientific Affairs. We have all set up in our profession, but the problem as practitioners is I sit down with a patient in the chair, and I'm not looking at a percentage risk of something on a population level. I'm looking at an individual, and I'm looking at an individual going longitudinally. Like, I'm going to be responsible for that patient maybe 15, 20 years. I have some patients in my practice who have been with me for my entire career and will be with me probably their entire life. And I know that you have patients like that in your practice. So it's like our challenge becomes, how do we fit that evidence that's taken on a cross-section and apply it to an individual, and we're looking at it longitudinally. Like, it may make sense to, we look at these risk factors and risk categories, and we look at the percentages, and that makes sense, but I'm sitting looking at this particular patient, and I'm thinking, I don't feel comfortable putting them on this strategy or not putting them on this strategy. I have to make a decision, and that's what diagnosis is all about. That's what we get paid to do as practitioners, is as diagnosis, is to take critical thinking, the pieces, and put them together and come out with your best judgment based on your experience and the needs and the wants of the patient. That's what evidence-based history is all about. It isn't just the scientific evidence. It's about your cumulative experience and knowledge and instincts, and then also wants the needs of the patient. So the whole cross-sectional versus longitudinal, I think, is an issue for us. So I really want to break this down and try and make it simple for you. I don't know if you guys have seen the movie The Usual Suspects, but in my mind, I have to tell you, I've been doing this Canberra for 12, 13 years in my practice now, and I do it on every patient. And it really comes down to I like to call them the usual suspects in terms of risk. Like, when I look at patients, typically they either have a back tissue, a diet issue, or a salivary issue. The end result is Kaiser-Sose there on the right. The end result is a pH problem. But if you start with bacteria, they typically either have too much bacteria in their mouth, they have too heavy of a bacterial load, or they got the wrong kind of bacteria. You've seen the patients that didn't have much bacterial plaque on their teeth, and yet they either had really high Caries screen activity levels, or they had a lot of decay activity going on. Another major risk here, another usual suspect, is diet. And typically, if they have a dietary issue, it's one of two things. Again, they either have too much sugar in their diet, simple sugars or hidden sugars in their diet, or they're eating too frequently. And one thing we know from a lot of John Featherstone's research, and that if you continue to eat frequently throughout the day, it drops, if we go back to the Stefan curve, it drops the pH in your mouth, and that doesn't recover for about 30 minutes in a normal mouth. And if you, again, are snack in between there, and even if you're snacking on something healthy, like carrots, it still drops the pH in your mouth. And those low periods, or those periods of low pH for prolonged periods of time, actually create a shift in the bacteria, and it favors down caries. And so you look at dietary issues. My third usual suspect is saliva. And typically, saliva is a big one. And typically in saliva, they don't have enough saliva. Their stomach, and there's a lot of reasons for that. And I've got a kind of a cross-section of a lot of different kinds of cases for you to look at tonight, and just to do with your own diagnostic skills. And the last thing I would say about saliva is they may just have really bad saliva. Like, they don't have good buffering capacity. The saliva, they have plenty of saliva, it's just not doing much for them. Now, we've been testing pH for 10 years, and it doesn't seem to correlate to anything. You can look at buffering capacity. The Erickson test works really well. Unfortunately, it takes about 3 hours to perform. So it's like we really don't have any good metric to measure the fact that they have bad saliva. But if they got plenty of saliva and I don't find anything else going on, I start to look at that may be the issue here. And if they've got this disease and they've got net mineral loss, I'm here to tell you they've got a pH issue. And so what we're trying to figure out is which usual suspects, and typically it's one or maybe just two issues that are driving this disease. And the beauty of that is it may only take one or two simple behavioral changes for that patient to try and correct it. Now, no behavioral change is easy, and it's a real challenge, and we're not trained on how to do that. And so that's a struggle for us as practitioners, and that's what I want to be able to ultimately help all of you with over the next period of this year as we move in that direction. And also we've got the wild card out there. It may be a combination of different things. You'll come up with an answer that you weren't expecting, and you have to dig deep. I'll talk to you before the night's over about a patient that I saw today that was very interesting. But let's do this first patient. And if you just start to think usual suspects, like I need to think back to diet and saliva. Looking at this patient, I'm diagnosing her at hello, as John Kutsch would tell us to do. I'm looking at this lady going, I don't even need to look at the risk assessment form. She has too much bacteria on her teeth. She has heavy plaque and bacterial load. I don't know what else is going on in her mouth, but right out of the gate, I see number one, this person has high bacterial load. And the visible plaque on the teeth in Featherstone's work was the number one risk factor, highest odds ratio for dental caries. So it's like if you see plaque like this, that's the issue. They have high bacterial load. So he got a 38-year-old female patient. She frequently visits the dentist. She's had a couple of surgeries with her childbirth. She's on birth control. She has, a normal blood pressure. Her pulse is a little hot at the moment. We look at her radiographs, and what do you see when you look at the radiographs? Are there interproximal radiographic radiolucencies that are indications of carious lesions? What kind of things do you see in the radiographs? Obviously, we've got some major issues going on here. Number 2 is to be extracted. Number 15 is going to be extracted. We've got some serious down 8 and 9. We've got lesions on 5. I look all over the mouth and we see, evidence of lesions everywhere there. So let's go to the Caries risk assessment form. This is the new form that we've been using since October. We've been training practices on. We've been collecting data on. And the first part is part of the motivational interview. The first question is engage the patient. Are you interested in getting a free screening today to find out whether or not you have the bacteria that cause cavities? And I'll give you data, but most of the patients, obviously, you're going to see that I'm going to share with you tonight are patients that are at risk for dental caries, and they were interested in doing something about it. If diagnosed, are you interested in discussing it today? That's kind of we're getting into the are you interested? I want to engage you in this process. Would you be willing to make some changes? And patients tend to be very optimistic about modifying their behaviors, in particular diet, because I think that's harder than I think most people would like to believe that it is. And then we get into the risk factors. The interesting part about this risk assessment form now, gray line in the middle, patients self-report their own risk factors to us. So instead of them having an issue in hygiene operatory of we don't have capacity in terms of time for hygienists to be filling all these forms out and doing all this work on top of the burden already got in that appointment, we have the patients in the waiting room fill out the top part and actually self-report their risk. And I have to tell you that it's dramatic. The difference between having a patient tell you they notice plaque on their teeth versus you telling them they have plaque on their teeth is huge. So I've identified a problem now that I recognize I have. I'm sharing it with you, and I'm kind of expecting that you're going to do something about it and you're going to talk to me about it. This patient, so notice they have plaque on their teeth. They drink other things other than milk or water more than a couple times during the day. So we go down to the disease indicators, and you're going to see kind of the terms on those change a little bit in the next month or so the indicators themselves aren't going to change, but kind of how we assess them is going to change just a little bit. But do they have visible cavitations? Yes. Radiographic lesions? Yes. White spot lesions? Yes. She's had a cavity in the last 3 years. We look at her biofilm challenge. She pegged the meter. So this is a patient that we go down to the assessment summary, and they have risk factors that are a concern to me. They have disease indicators that are a concern to me, and they have biofilm challenge that's a concern to me. She's out as an extreme risk dental care patient. This isn't rocket science. I mean, you see x-rays and you saw her mouth. This form should lead us to a number 5. She should be diagnosed as an extreme risk patient. And then to the right, you'll see a P, C, and D. And I use that for my own tracking, whether the patient, decided to take a proactive approach to treating it, or if they want to be conservative, or they decline to do anything about it at all. So let's talk about the assessment now. We know that she has plaque buildup, things other than milk or water more than a couple times in the day, and she had a very high bacterial load, which doesn't surprise us. So what's behind driving her disease? Well, she has poor hygiene, so we need to work with her in terms of behavioral management on home care to lower that plaque load, at least once a day, and she also drinks Mountain Dew. So two that we're going to address as we sit down and talk to this patient in terms of behavioral changes that they need to make, we need to address those 2 issues. And it's not a matter of you have to do 60 million different things. Here's just 2 major factors that are causing the majority of her disease issues. Now, the thing that we know from behavioral studies is that if I try to get her to do both of change that stuff at once, probably isn't going to work very well. Like the more things that we ask her to do that she hasn't ever done or isn't doing, the heavier we stack that with things, different changes to make all at one time, the less successful that she's going to be. And so that's a mistake. So what we want to do is substitute products for her. If she brushes her teeth, we want to substitute maybe a gel for a dentifrice, something that's going to help neutralize her mouth. We want to maybe get an electronic toothbrush and substitute that for the toothbrush that she has currently. And we're going to start doing that and just work on brushing like once a day for plaque removal, and we'll start there. You're not going to ask her to start flossing once a day, twice a day, and also give up Mountain Dew, and also make all these other changes at one time and start chewing this gum 5 sticks a day. And I'm not going to throw the book at this person because that's not going to work. So I'll start with one change. And actually, from coaching, we know the best thing to do is say, okay, here's 5 or 6 things that we need to work on. Which one do you think you're most interested in doing first? Which one appeals to you? Because let the patient dictate the treatment. If the patient says to you, you know what, I want to give up Mountain Dew. I want to do that first. You know what, let's start there. And so we're going to let the patient help dictate based on what works for them, because they know themselves. You know what works and what needs to be done, but they know themselves better in terms of what they're capable of. So that's part of our coaching program. Those are the kind of skills that I want to get into over the next few months as we teach that. Here's another patient. So again, I need to think usual suspects. Number 1, bacteria, saliva. You see here. I don't see any plaque on this person's teeth, right? It's like she doesn't have too much bacteria. She's taking Synthroid. She has fairly clean teeth. She brushes and flosses twice a day. I believe that. There's evidence of that. I start to worry. I see some saliva. I'm looking. Is there enough saliva? I don't know the answer to that question yet. But I go through the risk assessment form with her, and I don't really come up with dietary issues. So we start to look at this and go, well, what is going on? So here's a person who has a history of decay. They've got, if we look at the radiographs, you see these are actually some sandwich restorations. They are glass ionomer with composites. She's dissolving with glass ionomer. The person has a very acidic mouth. So what we need to figure out, when you see a patient where they're dissolving glass ionomers or composite restorations, you see that kind of appearance over a span of like 3 or 4 years, something's going on here. And it's not because she has too much bacteria. You go down to her risk assessment form, and said yes, and she's interested in learning about it. She takes one medication. Synthroid is not going to create xerostomia for her, so that's not one I'm worried about. But she doesn't have any visible cavitations. She has radiographic, radiolucencies on some restorations. She doesn't really have any lesions per se. She's actually dissolving restorations. She's had cavities in the last 3 years. She's had cavities her whole life. We look at her biofilm challenge. It's a little bit high. She didn't, certainly didn't peg the meter, so she has a high biofilm challenge. As we go down to the assessment summary, she's, red on all 3 questions. She is identified as a patient. She profiles out as a patient number 5, and she's to be proactive in terms of treating it. Now, what do you think's going on here? Right? And I get these patients when I scratch my head, and I'm like, gee whiz, I'm not really sure. And I just keep asking questions. And I see that this person has the wrong bacteria. She had, this bacterial disease, biofilm disease. She's had it. It still isn't corrected. She's got the wrong bacteria on her teeth. She still has an acidic biofilm growing there as evidence of it dissolving those restorations. So really, I just need to get her back into some neutralization. I don't really think xerostomia is an issue. Work with her just on that. And so that could be a substitution of a simple product. I can tell you that patient, that was several years ago. We put her on the oral neutralizing gel with the Floragel, and she's been free and I've replaced those restorations, and they're all intact. So it was just a simple substitution for that actually was successful. This patient number 3 here tonight, a 21-year-old male, comes to see me, grew up in a practice, decay-free, goes off to college and comes home. I don't see him for 3 years, and he comes home and he looks like this. Now, he's an athlete. He's got a baseball scholarship, so he's playing at a college baseball. He's a good-looking, young, athletic kid, fit, healthy. He tells me he brushes irregularly, and he picked up cigarette smoking while he was in college. So I'm looking at this, and I'm thinking, okay, what do you see? And again, think bacteria, diet, and saliva. Well, he's got some plaque on his teeth. I wouldn't say that it's excessive plaque. His diet, we're going to go through that. He looks like he has enough saliva. His teeth cleaned since he left for college, and here you see all these radiographic radiolucencies on his radiographs. This kid had like 20 lesions in his mouth. So the question is, like, what happened? Like, he graduated from high school, and he left a pretty healthy kid, and I see him like 3 years later with all these lesions. So we go through the risk assessment form. Yes, maybe, and sure. So I talked to him about it. He drinks something other than milk or water more than 2 times a day. He smokes cigarettes a day. As we go down through the disease indicators, yes, 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 and yes. He pegged them on the biofilm challenge. And risk factors, when we get down to the assessment summary, those are a concern to me. I'm concerned about his disease indicators. I'm concerned about his biofilm level. Again, this patient profiles out as a patient number 5. He chose to take a conservative approach to his treatment. Not every patient chooses to even be screened. Not every patient chooses to be active, and I'll share those percentages with you based on about 1,600 patients in a database. We'll do that at the end tonight. But so you look at this patient and figure, well, what's going on? Well, the only thing I picked up on his risk assessment form was the fact he's drinking something other than milk or water, and he pegged the meter with his TP score. So a really good phrase to use is "tell me about that." So I noticed you said that you drink things other than milk or water. Tell me about that. That's a non-judgmental question. It's open-ended. It's not a yes or no, and it's not judgmental. So more often than not, patients will go, "Oh, okay, so here's what I do." And that's interesting. Tell me more about that. And those are the behavioral skills in terms of communication that we weren't trained, in dental school. We were taught to look for holes in teeth and fill them up. And then we could be, good Dr. Drill and fills. But we need communication skills where we can look at a patient like this and look at the form and say, "That's interesting. Tell me more about that." And they share that with you. And as long as you're not judgmental about it, it helps you out. Well, it turns out that this kid got a base practice, and they had Gatorade at baseball practice, and he knew that it was good for him because it replaced his electrolytes, and he was worried about getting muscle cramps, so he figured it was healthy, so he started drinking it every day, all day. In fact, that's pretty much all he drinks now is Gatorade. Well, most people know this, but the number 2 ingredient behind water in Gatorade is sucrose. It's sugar water. I mean, it has all these electrolytes. It's great to carbohydrate load. It's great for athletes at an event, but it's not great to drink all day long. I mean, it's as bad as Mountain Dew or anything else. So here a young man thought he was being healthy for himself, and in the process ended up with a pretty serious Caries disease. Now, we need to go correct all those lesions, but the number one fact that we need to change for him is it's appropriate for you to drink Gatorade if you want to at your practice or a game, but it's the time I want you drinking water and work on your home care. But, we need to just make that simple switch. It's just one thing that's driving this disease. So I'm hoping this is making sense to you. Here's another patient that we'll go through, 36-year-old female. She had several surgeries, interesting surgeries, a complete abdominoplasty. She's lost 75 pounds. She's on a couple different medications. And so I'm looking at teeth going, okay, history of decay there. I see plenty, I see plenty of restorations in her mouth, and but yet I see, a couple radiographically going on today. So we go to a risk assessment form, and she's got clean teeth. She takes a couple of medications. Dave, I'm worried a little bit about xerostomia, but it looked like she had quite a bit of saliva. So she drinks things other than milk water more than a couple of times a day. So I showed the patient, I go, so tell me about that. Well, I drink black coffee. I'm like, oh, so I scratched that off my list because I'm expecting to find something I shouldn't. And we go through the entire list, we go through the entire program, and I'm like, I don't really know what's causing this problem here for you. The two medications you're on might be creating a little xerostomia. At the same point in time, when I looked in your mouth, you had a biofilm challenge. So what's going on isn't a function of you having too much bacteria, so I'm not going to put you on an antimicrobial agent. That's to start with here. But I'm trying to figure out what's going on. And so I keep asking the patient, and it's like, well, tell me more about that. Let's go back and talk about the coffee. How much coffee would you say that you drink during the day? Oh, I drink a lot. Oh, tell me about that. What is a lot to you? And she says, oh, I drink all the time. And I said, well, when you say all the time, do you mean like literally all day? Oh, I drink it from the time I get up in the morning. I would say I have coffee in my mouth almost all the time throughout the day. Well, coffee is 3.5. So I'm sitting here thinking, okay, I think we're onto something here. This coffee may be an issue. Tell me about the coffee. She said, well, I used coffee. That's how I lost the 75 pounds. I used coffee as my diet supplement. I drink it just basically day long. Drinking coffee just suppressed my appetite. Of course, caffeine, we know, triggers appetite. But for her having, her stomach full, and it kept her alert, and she used it to lose her weight. And I said, okay, this is very interesting. I did to see, quite frankly, more coffee stains on teeth. There were none, so she does a pretty good job. I mean, with home care. The issue here for her is, and I expressed it to her this way. So, you made a huge behavioral change in your diet, and you lost 75 pounds, and so you know about behavioral change. She goes, oh, absolutely. I said, okay. So the coffee, the acidity of the coffee all day long in your mouth is what's causing you to have some cavities now. What do you can do about that? How can we change that? She actually came up with a solution. Oh, well, I'm going to give up coffee. And I said, no, you're not going to give up coffee. I don't want you going postal on us. You're taking that much caffeine every day. Let's figure out another solution. So let's figure out that you have a couple of cups in the morning, maybe a cup break in the morning, maybe a cup with lunch, and maybe a cup in the afternoon, and maybe a cup with dinner. And after you get done drinking your coffee, let's have you rinse your mouth out with either an alkalizing rinse, or let's use a stick of gum or a spray, or even just tap water. That's neutral. Just swish your mouth really well when you're done with the coffee. And she says, spray. She goes, I'd love to have a spray that would help that out. I go, great. All you have to do is use this spray. When you're done with your coffee, take a couple of shots of the spray, and it's going to neutralize your mouth back to above neutral and no harm, no foul. And so that simple change for her, I'm going to see her again in a couple of months. That simple change may be all that we need to get for her to help her get this disease. He doesn't have, let me back up here for a second, and she doesn't have a bacterial challenge. So there's no point in me putting her on an antimicrobial agent. I wouldn't put her on the treatment rinse. It's not going to benefit her whatsoever. not going to put on any antimicrobial agents. She doesn't have a bacterial issue. She's an acidity, a pH issue that's coming from her diet. So as we just trace and narrow it down, it becomes a simple thing to make that behavioral change. So now I've got a patient that came to see me. I look at her mouth. She's got some crowns. She's got some decay history. I see a white spot lesion. I see saliva. So I'm looking around. I don't see plaque in her teeth. Her teeth look pretty clean. So I'm going right through the usual suspects. Bacteria, diet, and saliva. Well, unless it turns out she just got the wrong bacteria, I don't see too much bacteria. I see saliva. So unless you've had saliva, I'm starting to focus in on diet. Tell me about your diet. Tell me about that. So here we look at her radiographs. She's had quite a history of lesions. She's again dissolved some lesions. She has some recurrent lesions on 18 and 31. You look throughout her mouth, and we've got some dental caries issues going on here. How old the composites are. This is a new patient, but certainly we've got a disease issue going on here. So we go down through her chart. There's risk assessment form. She circled yes. She noticed plaque build on her teeth. They look fairly clean to me. In the huge spectrum, they didn't look that bad. I drink things other than milk or water more than 2 times a day. And here's one. I like to snack 1 to 3 times or more daily between meals. I said to you about that. So the patient says to me, well, I eat my diet. I don't eat like 3 meals a day. I tend to eat like more smaller meals throughout the day. And I said, oh, that's interesting. You mean like maybe 5 small meals and then you have one like lean and green meal at dinner time? And she goes, that's exactly what I do. I said, okay. Tell me about that. She goes, well, I'm on the Metafast diet. Great. That's wonderful. And you've lost, can't remember off the top of my head, she told me she'd lost like 60-some pounds. And so using that, so we look at that. We process, and she's basically on the Metafast diet. Now, why is that an issue? Yeah, she lost 60 pounds. Why is it an issue? One thing we know from research, how frequently you eat is more, or let's say more of a risk factor for you than what you eat. And so I use this analogy. I know that it kind of sell some people, but you'd be better off having a snack in the morning of a bag of M&Ms than to eat carrots all day long. And the reason every time you eat, the pH in your mouth drops, and every time pH drops, you lose some mineral out of your teeth, and your biofilm becomes acidic. And if you do frequently enough throughout the day, it doesn't really get a chance to recover, and so that drives the selection pressure. The low pH in the mouth drives the selection pressure for the cariogenic bacteria, and that's enough to create the risk factor for this disease. So again, for a patient like this, the conversation is, I commend you. 60 pounds is awesome, and you look wonderful, and I don't want to change that for you because you're doing really good. Here's the challenge that diet plan is created for you, and here's how we can simply manage it. Again, the same kind of issue. After you're done having your small meal or after you have your snack, all we have to do is just raise the pH in your mouth, and here's options. You could rinse your mouth with water. You could use a fluoride rinse. You could go brush teeth and floss. You could chew some gum. You could use a spray. Well, here's a patient that says, I love to chew gum. I'm like, oh, great. Well, let's just chew this gum after you get done having your small meal. Raise your pH in your mouth back up. It has xylitol in it, and let's try that. But again, it's just a simple issue here that if you didn't ask that question, like this lady been going to her dentist and just kept getting cavities, and surprised, it's like, why didn't somebody tell me this? Like, this is all I have to do? Why didn't somebody share that with me? And it's like just a simple matter of us going through this to figure out what's going on. This is a 71-year-old patient that came in to see me. He takes a Tenolol for high blood pressure. His blood pressure is pretty well regulated. His pulse is normal. It's been 2 years since his last recare visit. I'm looking in the mouth, and it's like, what do you see? Well, I'm kind of looking around. I'm thinking, well, God, I think the tissue looks pretty dry here, particularly on the top, maybe even on the bottom. I don't see a lot of saliva pooling in the bottom of the mouth. I'm looking at the radiographs, and it's like tooth number 2. Got a huge lesion underneath that that I'm not sure. In fact, I can tell you it ended up being extracted. Tooth number 6 had a huge lesion under that restoration that tooth ended up needing a root canal. So here's a patient that comes in 2 years later and has obviously got some issues going on. So we go to the risk assessment form. Yes, I want to know about it. Maybe I discuss it, and I could change, but I don't want to. Okay, that gives me a bit of information to help manage this patient with. So they're taking one medication, the atenolol. I'm pretty sure the atenolol is going to be creating some level of xerostomia, so that's a concern to me in my mind. I'm not taking them off the atenolol, but I think that we've got some xerostomia issues going on here because of that. And the patient reported to me, I suffer from dry mouth at times during the day. And ask the patient when that, or they respond to that, ask them, well, how is it at night? Do you ever wake up in the middle of the night with a really dry mouth? Because what happens is nocturnally, your salivary production reduces significantly. Otherwise, we'd fall over our pillow or we'd choke on our own saliva. And so while we're asleep, our saliva production goes down dramatically. And so typically people that have xerostomia or suffer from dry mouth, they suffer from it like in the middle of the night. I'm talking 2 to 3 or 4 o'clock in the night. They wake up and their mouth is bone dry. And if they're a mouth breather, it's even worse yet. So a person like that, it's not just during the day, but the question for me is I really want to know how things are at night. Then the patient expressed to me that, gee, my mouth is really dry when I wake up in the middle of the night. Okay, so I noticed that you've said that you drink things other than milk or water. Can you tell me about that? Well, I drink iced tea. Wow, that's nice. I mean, I love iced tea. So tell me about the iced tea. Do you put sugar in it? Do you use honey? Do you like it sweet? How do you like your iced tea? I'll get it black. Okay, so that's probably not an issue. So it's probably not dietary. I'm headed more towards saliva here. If you guys are all following me, the usual suspect here for me seems to be saliva, not necessarily diet. And I said, well, tell me more about the iced tea. How much of that would you say that you drink a day? Oh, I drink a lot. And okay, so what is a lot to you? I mean, how much iced tea do you make every day? Oh, probably a couple of gallons. That's interesting. So you drink like 2 gallons of iced tea a day. Yeah, I would say probably something like that. Really? Tell me about that. Oh, I even keep it on my nightstand. When I wake up in the middle of the night and my mouth is really dry, I have a glass of iced tea right there. Now, the tea is about the same as coffee, and so it's like this is so we've got a pH issue here because of the diet. We also have some xerostomia. This is a recipe for disaster, and ultimately we lost 2 teeth, or lost 1 tooth and need a root canal on another. So as we go down to the disease indicators, visible cavitations, radiographic lesions, thin white spot lesions, had a cavity in the last 3 years, a low bacterial assessment. I swab the teeth. So this, again, a person I'm not going to put on, going to put this person on a microbial agent. It's not going to do them any good. They do have factors. They have disease indicators, so we're going to address those particular issues, but I'm not putting them on an antimicrobial agent. And so I put them on a gel and a rinse. So I hope you're starting to kind of get a sense for, so this is the assessment. And I have patients that do all kinds of unusual things. I've just picked out a few of mine here to share with you. But you see people do weird stuff, and you have to ask the question because it's like, gee, you drink coffee. Okay, so suddenly it's like that's, the red flag that was up is gone, and then I find out, well, they're drinking black coffee. They literally are holding it in their mouth, 24/7. Okay, well, that's an issue. So these are the kind of things that we need to kind of get through. Even in the middle of the night. And it's literally, as I talked about the iced tea, I don't want you to give up iced tea, but let's try and rather than drinking it all day long, let's try and, spread some water, or maybe rinse your mouth out with some water when you're done. And at the end, the one that's hurting you the worst is the one in the middle of the night. Could you put water in your nightstand instead of iced tea? I mean, that's the first simple change that we made with this guy was just, I'm going to have you have water instead of iced tea on your nightstand. I mean, we just need to make these baby steps. It's evolution, not revolution. Patient number 7. This patient actually found me on the internet, flew completely across the country to see me. An attractive young woman. She comes in a business suit. She is a young business executive. Her hair and makeup, I mean, she is well groomed. I look at her teeth, and I'm looking at here going, well, I don't see I see plaque buildup on your teeth. Your teeth are reasonably reasonably clean. Looks like you do a great job. She tells me that she flosses. I believe that. She tells me that she doesn't have any sugar in her diet. She's had 6 new cavities in the last 2 years alone, and she continues to get cavities, and her dentist told her that she needs to floss more. And, I mean, this is one of the, I think, the traps that we fall into as a profession. We assume that it's because they're not brushing and flossing, and that, once they tell us they are flossing, we think of one of 2 things. Either they're lying, or number 2, they don't know how to floss correctly. So you must be doing it wrong. And you're again not going to get anywhere with that kind of language with patients like this. I told her I couldn't help her over the phone. I wanted to refer to somebody in her area that could help her, but she insisted on coming to see me. So of course, I'm happy to see her. So I look at this mouth, and I look at it. First thing I'm looking at is like, where's the saliva? This tissue is really dry. I'm going, okay, so she's taking Wellbutrin and Ativan. Okay, those both create xerostomia. So immediately, I'm not thinking diet, I'm not thinking bacteria, I'm thinking saliva here and xerostomia. So we're looking at the radiograph. She's got some lesions that are already started. Again, you can see between 18 and 19. She's got a lesion underneath a restoration that was performed, I think, in the last year or so. She's made dissolving glass ionomer there on the distal of number 29. It looks like on the distal of 4. This is a person that's got an acidic mouth. But the reason that we got to figure out is like what's driving this disease. So we look at a risk assessment form, and the only thing I'm picking up on risk assessments is basically the medications. And we go down through this. She had radiographic lesions. She has cavities right now. Her bacterial challenge was high. She profiled out as a number 5, which is appropriate for her. But I have to tell you, this person was assaulted by the fact that her dentist told her that she needed to floss more. She's, I floss every day. And, that we as a profession need to, maybe take a different approach to this. So you look at her mouth, and we tend to, as dentists, to get focused on this crown that we think maybe doesn't look a lot. So that's what we look at first, because we're all trained to look at that. But here's what I'm looking at. I don't see any saliva here. And so, I start asking her, do you have a dry mouth? And we start talking about that. And she, in the midst of the conversation, shares with me that her mother was just diagnosed with Sjogren's syndrome, which is a hereditary disease, an autoimmune disease of the salivary glands. And so I said, you might want to get tested for it. It may not show up really for another 10 years for you, but right now you have dry mouth, and the reason you got dry mouth is more attributed, in my mind, to the 2 medications that you're taking. But that's what's causing this disease. And so it's a matter of, we need to figure out how to compensate for the fact that you've got a dry mouth during the day and start alkalinizing, neutralizing your mouth so that we can get healthy bacteria growing, and you'll stop getting cavities. So she has medication-induced xerostomia, and my recommendation is that be tested for Sjogren's syndrome. This patient comes to see me, obviously, so now she's taking different medications, one for bipolar disorder, one for high blood pressure. She tells me she has a dry mouth. It's obviously not as dry as the last patient, and a pretty high ATP score, bacterial score. She's got some plaque on her teeth, so we look at radiographs. We see a lot of stuff going on here, a lot of history of decay, a lot of decay right at the moment. We go to the risk assessment form, and we're going, yes, sure. And I'm looking at, she's taking 2 medications right now that are concerned to me. She suffers from she self-reports xerostomia, and she likes to snack, frequently throughout the day. So we talked about that. So number 1, we've got diet's an issue. So this is a combination. We got a bunch of things going on here. Number 1 is diet. She's had xerostomia because she's self-reporting it, and she's also taking 2 medications that cause that. So, but I'm looking at this going, we've had a serious breakdown on your teeth, and kind of thinking, wow. I mean, just from that, the amount of decay you got, the teeth you've lost, there seems to be more going on here than meets the eye. Tell me about that. Tell me about the dry mouth. About other medications. You take any other medications? Well, here's a patient that has been a meth addict in the past. She's been clean for a couple of years, so that's not a risk. That's why you see more saliva. If she were a meth addict right at the moment, you wouldn't see hardly any saliva at all. But a lot of this damage was created then, and we're dealing with the damage created from her meth addiction early on. So this is a patient that's going to be a challenge to manage. I work with a clinic on teenagers that are suffering from meth addiction, and I have to tell you, I really don't have any success stories on meth. I mean, I can get their teeth and get them clean for a while, but the problem is, after a year or two, you end up back on meth, and it's a heartbreaking thing. So I know that you guys all see these in your community, and it's just an awful drug. But it just really destroys the teeth. So I brought, as I continued to get to know her and continue the conversation, tell me more about that. She, confessed that she was a meth addict at one time, and so we started working with her and actually restored her entire mouth. Patient number 9 here. Here's a patient I've been seeing for a long time. This patient is just a great patient. Really concerned about her health and wellness. She's, very active brusher and flosser. Maybe a little too aggressive at sometimes on some of those things, but so she comes to see me. She's concerned because she has a real history of decay. Now, I currently don't see any lesions in her mouth, but she has a real history of decay. She's orthodontic treatment. I mean, you go look through her mouth. She's had root canals and crowns, and she again found me on the internet. Want to know what was causing all the cavities in her mouth, and just didn't want another cavity for the rest of her life, and came to visit me. We go down through her reform. Yes at the top. She notices plaque buildup on her teeth. I actually complimented her on her home care. She does a very good job. The only real risk factor here is she likes to snack, and she snacks quite frequently throughout the day. And she's, thinks that she is maybe going to change that behavior, but the reality is she realizes that she eats small meals, she eats small amounts at a time, she eats frequently. She's been aware her entire life, and that's going to be a challenge for us to change for her. Her biofilm challenge was high. Currently, she didn't have any visible cavitations, white spot lesions, radiographic lesions, and she hasn't had a cavity in the last 3 years, but she really just wanted to be proactive and not ever have any more decay. So we talked about, well, here's what we need to do. What's an issue for you? The usual suspect for you is diet. The frequency is what the issue is. I mean, this person is very concerned about her health. She's a vegetarian. Works out, does yoga. I mean, I go down the list of all the things this patient does. So it's like, here's a highly motivated patient that it's easy to work with in terms of making behavioral change. And again, it's just a matter of, after you eat, we just need to neutralize your mouth. And so here's some options. Tell me which one you think fits best for you, and let's try that first. So this patient's been with me for 3 or 4 years now. She's been decay-free, but, it's a delight to see. So it's just really a function of, for this person, it's a diet that doesn't have an issue right at the moment, but doesn't want an issue. And so you're going to see patients like that want to be proactive about it. Patient number 10 here, 58-year-old male, same age as I am, a lot of medications. He has a history of oral cancer. He had head and neck radiation twice. So that should be he had 2 different bouts of oral cancer, so that right out of the gate should be a red flag. So I'm looking at, the radiographs here, and I'm not thinking bacteria or diet. I'm thinking saliva. And you can see lesions that we've got around some of his restorations. We've got a lot going on here. So as we go down that whole list, again, I'm going cutting right to the chase here. This person, we got xerostomia. He's got an elevated bacterial challenge. He profiles out as a number, wants to save all of his teeth, is highly motivated to work and do that. And so this is a patient that is highly xerostomic. His teeth are dry. It's a real challenge for us. So what are you going to manage this patient? Well, I would put them, again, probably going to do some antimicrobial therapy, probably going to do that on an ongoing basis for him because he does have a high bacterial challenge. But I'm also going to help neutralize the pH situation in his mouth and put him in a tray. And I would do this also for Sjogren's syndrome. These are my protocols, is to put them in a neutralizing gel at night in a tray every night for the rest of their life, both upper and lower arches. So make them bleaching trays. I wouldn't necessarily put them on the fluoride gel HA, but I'd probably put them on the oral neutralizing gel with the HA in it. So this is what we've done for him, and I've actually maintained this patient for 3 years decay-free. So this is radiation xerostomia. Patient number 11 comes in to see me as a new patient, got fairly clean teeth. So again, start thinking usual suspects, bacteria, diet, and saliva. Well, I've got, the teeth are pretty clean. I'm not seeing too much bacteria, so unless we got the wrong bacteria, I'm not going down that one. As I get through the medical history, we're taking Zizal for hives. Zizal creates xerostomia. That's a strong antihistamine, and this person has idiopathic hives, and they take this on a daily basis. So they're otherwise not taking other medications. As I go through look at the radiographs, we've got some things going on here. Risk assessment form, and I'm thinking saliva. I'm looking at the diet, and as I look at all the risk factors, it primarily is the two medications, or the medication this patient is taking, and reported to me they suffer from dry mouth during the day and worse so at night. Have a high bacterial challenge. I'm going to put them on an antimicrobial agent if they want to be proactive. This patient want to take a conservative approach. We're using just a rinse and a gel, 5,000 part per million fluoride gel. So we're approaching it that way. So it's really a matter of, this is medication-induced xerostomia. It's related to a systemic condition that she has. Simple thing. Patient number 12, 21-year-old male. Had 26 new cases in the last 3 years. Brushes regularly and is a cigarette smoker as well. And so I look in the mouth and you see a lot of lesions. Has lost some teeth, has large radiographic radiolucencies indicative of Caries lesions in his mouth. A lot of things going on there. We get down through the risk factors. And yes, notices plaque buildup on her teeth, takes 3 different medications, suffers from dry mouth during the day. We go down through the disease indicators. He's yes on all 4. He has a pegged the meter on the biofilm challenge. His profile's out as a patient number 5. And this patient decided to take a conservative approach. We start talking about, tell me about the medications that you're taking. He's taking albuterol for asthma, strong xerostomic medication, written for ADHD, and an antihistamine daily. So this patient has a dry mouth. Now, you see a little saliva in the back next to his cheeks, but you look in the bottom of his, his tissue is dry, his gingival tissue is dry, and his mucosa is dry. So this is really a patient that has, I would say, a combination of things going on here. Certainly, we've got medication-induced xerostomia, even in a young person. He's 21 years old, but we also maybe have too much bacteria here. I want to put him on a microbial agent, and there's some plaque buildup on his teeth, so a couple of issues that I want to work with. Now, I can't take him off his medications, so what we need to do is balance. Go back to the Caries balance or imbalance that Featherstone and Doug Young have discussed and published about, and start thinking about what kind of protective factors I add for you during the day. Diet's not an issue. It's just strictly this is a medication-induced issue, and we're going to talk about home care. We're going to try and make some of those changes, kind of, again, one at a time. This is an interesting patient that came to see me recently. Again, taking estrogen daily. Mouth, and again, so it's like the question is, think usual suspects, bacteria, diet, and saliva. What do I see? Well, I see some bacteria. There's some plaque on those teeth down there below. I don't know what the diet's like yet. Likes to snack. Okay, so that's kind of a red flag for me. And I don't see a lot of saliva. I don't even see any pooling at the bottom of the mouth. This patient's 50 years old, a female. Lot of teeth. When we look at radiographs, had an implant, got some, lesions going on. Got it. 17, 18, or 19, 18 and 19 and 20. 12, 13, 4. Everywhere I look, I see decay. So we got, of course, the implant doesn't have any decay. So we got a lot of different issues going on here. We go through this, and I get down to this. I'm asking the patient, tell me more about that. Do you have dry mouth? Tell me about that. You've got biofilm challenge. This is a person I'm going to put on an antimicrobial agent. But if you profile out yes, 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 and yes, you don't have any white spot lesions, but we've got everything else going on here. So I started talking to her about, the dry mouth and talking about other conditions, and she shares with me that she's been diagnosed with Sjogren's syndrome. So again, this is something that just came out, in the interview after we looked at the risk assessment form. I was ready to blame this on the two medications that she's taking, although Aleve, is an anti-inflammatory, and Estroven is a hormone replacement therapy. So I'm not really expecting either one of those are creating the xerostomia, so I'm wondering what's going on here. So as we get to talking about that, it turns out she has Sjogren's syndrome. So I'm going to treat this patient just like I treated the radiographic or radiation xerostomia. I'm going to put her in a tray at night, every night, for the rest of her life, deal with that. So the one behavioral change that she needs to make, we're going to slowly work on home care, we're going to slowly work on everything else, but the one real behavior change for her is going to be wearing trays at night. Otherwise, she's going to lose her teeth. And we'll talk, on my next webinar, we're going to get into staging. How do you stage the treatment? I've got two patients left here that I want to share with you. This patient came to see me, and her, she wants a new bridge, and she wants veneers. And I look in her mouth and go, okay, that's not going to happen. I get red flags are popping out all over for me. You've got hypertension and hay fever. You've had a partial hip replacement. You're taking multiple medications. I'm looking in the mouth. I see dry tissue, mucosa on the maxillary. I see damp tissue on the mandibular arch. But we've got some major issues going on. If I could schedule you tomorrow. We could put veneers on all your lower anterior teeth. I could make them look beautiful. We could put a new bridge. We could put veneers on the rest of your upper teeth. We could spend $20,000 tomorrow. I could appoint that. But I got to tell you that would be malpractice, in my opinion, until you figure out what's causing this disease and you get to the root of it and start helping this patient get back to health and wellness. Treating cavities first or doing that kind of cosmetic treatment is like inappropriate, and it happens too frequently in our profession where the patient wants this or that, and it's like they get it, and the practitioners aren't diagnosing what's causing the disease in the first place. Here we've got lesions on the upper teeth, got lesions on the lower teeth, lesions on crowns, and to tell you, if we went and did all the restorative care for her before we figured out what was causing this disease, 2 years from now, maybe less than that, maybe a year from now, 2 years from now, all those restorations that we just placed would have recurrent lesions on them. And until you see that, from a patient that had 20 Da Vinci veneers and they came in 1 year later with 22 lesions on these veneers that they had done, understand why they have all these cavities. That's a real issue. The drill is not the treatment. Is not, drill and fill is not the answer for this disease. We need to kind of, I think that in our profession. Right, so she's taking multiple medications. I'm thinking right out of the gate, xerostomia, medication-induced xerostomia. We've got plaque buildup on her teeth. And again, so this is a patient that has, as we go through this, she's a high-risk patient. She's got too much plaque on her teeth. She's taking multiple medications, going on to antimicrobial therapy to start with, and then we'll start talking about staging the restorations. I want to encourage her and let her know that, yes, I can certainly do that for you. You can have a new bridge. You can have a beautiful smile, but we need to get you healthy first, or $1 that you spend certainly may be a wasted dollar a year or even 2 years from now. And so she really, grabbed hold of that and said, well, then let's figure out how to get me healthy, because that's what I want. And so, here's an issue of medication-induced xerostomia, and I really want to work on her home care as well. The patient I'm going to share with you tonight, the patient came to see me about 3 or 4 years ago. He was 43 years old. I took one look in the mouth, and this is a disaster. Like anything you do to these teeth is probably going to get destroyed. This guy is breaking down dramatically, making not only sound. He tells me that he brushes regularly. Okay, he's doing a reasonable job. Let's say I don't see caked on his teeth. I don't see a lot of marginal gingivitis, but his teeth seem to be dissolving. And so you start to think, is this a meth addict? Have we got xerostomia going on here? You start to think, I'm not comfortable proposing a lot of restorative care for this individual. Turns out he's a college professor, and his driving factor here is he's embarrassed from his teeth. He's afraid to get up and lecture in one of his classes because he's so ashamed of how his teeth look. Well, I get into it. Well, tell me, what do you think caused this? And you can look at the radiographs here, and we've got a serious issue, a serious challenge for this person. He was in an automobile accident in 1988. He had suffered migraines. He had a serious head trauma. He was on Demerol for over 20 years on a daily basis. And, you know, what happened to him here was a progression of xerostomia that wasn't caught and treated and wasn't dealt with. And so as we go through his risk assessment form, high biofilm challenge, I mean, he's taken multiple medications, and so I sit down and do my normal routine with this patient, and I'm thinking dentures. You know, I'm thinking that we're going to reduce your restorative risk and have the highest predictability for treatment outcome for you. We need to move you toward dentures because, you know, we got some serious issues going on here. Well, I didn't see this patient for a year. He left and he didn't come back. A year later he comes back and he has lost weight. He stopped smoking. He is working out. He's juicing. He got off his medications and discovered that he doesn't need Demerol anymore. And so the guy's healthy, but he's got, you know, some of these lesions in his mouth, and he wants to save his teeth. And so I can't promise that can be done, but I mean, if you're interested, the first thing to do is let's get all the decay out. Let's go through the antimicrobial therapy. You know, we need to run multiple things here, but you're making behavioral changes in your life, so, you know, I'll help coach you through this process. Let's start with one change at a time. I got him in. I put glass ionomers in all of those. That was stage 1. This was probably 3 years ago, and I told him he had to be decay-free for 2 years before we consider doing anything else, so we put in a flipper. We put in glass ionomer restorations, and this guy, you know, over a period of 2 years maintained health. His bacterial counts down. We got below 1,500. So this was phase 1. Then we spent a year working on the upper teeth. Actually was able to save most of those teeth. Number 6, there is a temporary. I just placed an implant. We're waiting for it to heal. In the next year, we're going to start restoring his lower arch. So it's possible to get, and this was a life-changing experience for this patient. I have to tell you, this was life-changing. And we're 4 years into this process. He hasn't had any decay in his mouth. I know that we're swabbing him, and I mean, this is a high-risk patient. Doing this is risky in terms of long-term, but I've got a really compliant patient who's highly motivated, so I feel comfortable working with him. And he knows what the risks are. We've been through all of that. But, you know, this is been a life-changing experience for me as well, because this individual comes now, and it's an interesting experience because it's literally changed his life. So just to share some data with you, based on 1,447 patients from 5 different practices now, you know, the response to the patients on the free screening, 73.64% have said yes. They've profiled about 2% or low risk. Moderate risk, 25% basically. High risk, about 25%. High risk that have low biofilm challenge, about 20%, and about, again, like in the neighborhood of 25%, are high risk and extreme risk, and have all of those issues going on. And we've got about 44% in all of these practices. Patients are accepting some form of treatment. Now, the reason my practice are higher than that, I've had, you know, a lot of experience doing this, but this is realistic because these are real practices that we've coached and we've trained, and these are the real numbers. So we're going to continue on probably a 2-year to 3-year clinical trial, collecting this kind of data, because I think it really gives us a real first look at what happens in private practice. I want to kind of end with that tonight. I really appreciate you guys sticking through this. Maybe we had too many cases tonight, but I think that the more cases that we see, the more we start to get a feel for how this process works. But it's really that interview with the patient. The risk assessment form is not to tell you whether or not they have decay. It's to answer the why do you have decay question. I use that form to lead me through the Colombo investigative process of why do your teeth look like this? Because if I can figure out the why, and typically it's one of those usual suspects, and typically it's just one thing, and you know, typically when I can identify that, then for the patient, we really have to work or focus our treatment around one thing in terms of behavioral change. So I tried to simplify this for you tonight and kind of get a feel for the flow, how this works. I hope that you found it useful. I think we'll continue to look at additional cases and maybe some moderate risk cases as we continue this seminar series. But I really want to get into next on how to stage the treatment. What do you do next? Which patient, take 3 or 4 patients, and let's say, what do you do for this patient specifically? How do you stage out the care, and what do you do for that patient? Because those are the things that you guys really need to know. You can help do this in your practice. So that'll be next, and then eventually we'll get into wellness coaching. So Kendall, I know we've run over here just a little bit, but I know that almost everybody is still with us. So if we got time let's have a couple of questions anyway. And I guess, and then Kendall, you can talk to them about, if they have questions or they want to learn more, they can contact, if you're currently a CariFree client, you can contact your trainer and go through the new risk assessment forms with or get more training on that. And if you're not a customer and you'd like to be, you can visit, CariFree, visit CariFree.com and join our team.
Yeah, absolutely. Well, of course, if anybody has to break off the phone, that is not a problem at all, but we will stick on here and take a few of the questions. We do have quite a few coming in, and thank you to Dr. Kutsch and to everyone for all of your great questions. So we'll get through as many as we can. The first question that we have is, where in the practice are you implementing this program? Do you also have your hygienist talking to patients about their risk factors?
And Kendall, and whoever asked, this is an excellent question. And I have to tell you, this is the mistake that I think that I made and that we as a group, in the profession have made. I started by putting this in the hygiene department. And quite frankly, that's a capacity issue. Hygienists don't have time. We can't continue to just add more responsibilities to them and have that be successful. And so we got a lot of pushback, and I think anybody that's tried that has gotten a lot of pushback from their hygiene department, and reasonably so. Where we implement this is every patient that comes into my office once a year fills out a new risk assessment form, and I swab them all as a screening test at least once a year. And that's ones that are yes to that question of whether or not they like a free screening. I do have the hygienist identify the disease indicators, and if they have time, they talk about diet, they talk about, whatever those risk factors happen to be, help educate the patient. Hygienists are the best educators in the world. I mean, they can sit with a patient. They have such a tremendous wealth of knowledge on all of these topics that they're really good at that. I like to come into the hygiene operatory and share the diagnosis with the patient, go through my thought process, and ask those questions. Tell me about that. If it's a new patient I've never seen before, I really want to go through that myself. Spend about 10 minutes in an interview. Tell me about that. Tell me about your diet. Tell me about the medications you take. Tell me about your previous decay history. Tell me about expand. Can you expand? That's interesting. Can you expand on that? I ask those questions because I really want to have that information when I go through that critical thinking process to make the decision. I'm going to be directing and coaching the patient primarily with the help of the hygienist. So I want them to talk to them if they have time. Otherwise, I'm happy to handle all that myself. But if they have that appointment, if there's 5 minutes left, I'll tell the patient, the hygienist here is going to, our partner here is going to talk to you about diet and maybe help you with how are we going to coach you through making this one change, or talk to you about maybe using this product. So I kind of integrate it, but I don't put this thing on the shoulders of the hygienist, and we did that at the start, and that just doesn't work. Question. Thanks, Kendall.
Yes, excellent. And the next question, I think I will ask this. I know it's something that you would like to cover a little bit more in depth on future webinars, but we have been getting quite a few questions about it, so I'll have you maybe just talk briefly about it tonight, and we can always dive in a little bit more looking in the future. What is the timeline regarding treatment for these patients? How often do you see them back, and what do you do during a reassessment appointment? Also, how do we know they are on the right track?
That's a whole webinar in itself. Great question, and actually that's our next webinar. So I really can't, in a couple of minutes, do that complete justice, but what I would tell you is that changing the biofilm is a long process. There is no silver bullet. We all want a silver bullet. We all want that. We were all trained to think that way. We're trained to see a hole, drill it out and put a hole in it, fix it now. And disease doesn't lend itself to that. This is a chronic disease. It's a complex biofilm disorder. Biofilms are strongly resistant to change, so it takes time to get that to accomplish. So, I mean, some of these patients that I showed you were 3 months, and some of them were 3 years. And every patient's going to be a little bit different depending upon what the risk factors are. How often do I see them? If they're a Category 5 patient, I see them every 3 months. I give them 3 months worth of product that I want them managed on in that period of time and using, and I coach them. So at that recare appointment, I sit down and go, tell me about it. How's it going? You know, instead of like, you know, you're not flossing enough, or, you know, accusing them this or that. It's really, it's what I have to do as a coach. I have to hold them accountable. This is what you agreed that you wanted to do. This is what you decided to do. Tell me, how's it going? Tell me about it. So is that working for you? Are you making progress? And then the other part of that is, as their coach, I need to be in their corner cheering them on. And I need to be encouraging them. If you think of the psychiatrist sitting down and saying to their patient, you know, you've just made no progress at all, you're an absolute and total loser, the person's probably going to commit suicide because they're already depressed. Well, we've got a patient here that's trying to get healthy. They're struggling. The behavioral issues are a challenge for them. They're not easy. I understand that. So what I need to do is hold them accountable, at the same time encourage and support them. You know what? You've made great progress. Yep, maybe your ATP score didn't come down, but you know what? You're doing really good. I want you to I want to encourage you. You know, don't quit. Don't give up. You're making great progress, and it's 2 steps forward and maybe 1 step back, but keep at it because you're doing a great job. So I want to encourage that patient rather than discourage them. And so that's like I said, that whole topic is a long, it's a webinar's worth, and I really think it's a great question, and that should be our next webinar is, you know, how do we address that? Because I know that's what everybody needs to know. How do you manage this in your practice? And so that's where we'll head next. That's a great question.
I think we'll stick in and just answer one more question here. So we have had a few questions coming in about the PCD that you had mentioned, and I don't think everybody is totally familiar with that. So going back to that, there are kind of 2 parts here. How do you approach the different treatment levels with patients, and then what are you doing with the PCD information as far as tracking goes in your practice?
Okay, that's like 6 questions. So let's go. A couple things that we skipped over here tonight, Kendall, which we don't have in front of us, which maybe that's the next step in this whole process, is we have once you have identified the patient as a 1, 2, 3, 4, 5, we have a professional treatment guide, which is the decision tree on what to do next. Like, what kind of treatment would we recommend for this specific, like, number 3 patient? What would we recommend? And one of the things that we found is that by trying to sell the patient something, the natural resistance is to, like, resist buying. Whereas if they're given an option, like a board of, like, okay, so you've got this disease, here's what's going on, here's what's causing it, and here's some options we have on how to approach treating it. Would you like to be proactive about it? You know, really go after it? Are you concerned about losing your teeth? Would you want to take more of a slower, conservative approach, recognizing that probably is going to take longer, or you just not want to do anything differently at all? And so we've given the patients options on different levels of care. We have those specific recommendations spelled out. We didn't go through that tonight, and we'll go through that in our next webinar in the series. But give patients the option to do nothing and have the option to choose the level of care that they're interested in. Provides us with a much better acceptance of our treatment or strategies than if we were just trying to direct them and sell them, and you've got to do this, and sell them on a single idea or sell them a product. So it's educating them, giving them options, and then coaching them through that process. So that's really, and then PCDs, I track in my own practice, and I actually collect that data, and I can tell you what exact percentage of my patients that were diagnosed as number 1s chose to do PCD. I can tell you patients number. I can tell you for all levels of patients, I track that. And how do I use that? I'm going to be using that to help my own patients with. We have John Featherstone's data from his research that indicates, if you're a number 5 extreme risk patient and you choose to just have your teeth filled and you don't do anything to treat the disease, you've got an 88% risk of having a new cavity within the next 12 months. And so, that's just, if you're okay with that, I'm okay with that, because my kid to go to college too, and if you're happy, spending $300 on a filling next year, I'm okay with that. But patients given those opportunities, I think, make more or better informed healthcare decisions for themselves. And so the PC data for me is to help me track what I'm doing, like how we as a team doing in terms of getting patient acceptance of care. And then I also get a profile of what kind of patients, and I have to tell you that the number 5 patients are more likely to choose Proactive than any other patient, because they're in a worse situation, and it's like they need to get aggressive about this now or they are going to lose teeth. And my low-risk patients are the most likely to decline anything, because hey, they don't have any issues going on, and why do I need to change anything whatsoever? We just need to educate them that risk factors do change over time in your life, and you may be low risk now, but you may not always be low risk. But given us, I like the patient to have the options and be well educated, well informed, and make their own decisions for themselves. But I like to use that data. I hope to be able to, with my own practice data in the next couple of years, be able to tell a patient, if you're profile number 3 and you choose to be conservative in your approach, you can expect that you can have success, but maybe it's going to take 3 years instead of 1 year if you wanted to be proactive. Or maybe if you decide to take a conservative approach, you've got a 50% chance of getting a new cavity in the next 2 or 3 years. I like to have that kind of data because, it's like, if you're sitting talking to a health practitioner and you got an illness and you've got options, I want to know, well, what are the odds? What are the percentage chances of me? How long is it going to take if I choose this pathway versus I choose that one? And so we don't have that kind of data. We've never collected that kind of data in the history of our profession. So for the first time, we have John Featherstone's data from the university, but for the first time, we're going to actually collect that data from private practice. So we'll have data to share with patients, which I think will be more meaningful. So that's what I hope to do with it.
Awesome. Well, I think we will probably end there, and I appreciate everybody that has stuck with us here, and just appreciate you for, taking out the time tonight. And we obviously weren't able to answer all of the questions coming in, so we will be replying to them throughout the week via email. And again, like Dr. Kutsch said, for those folks who would like more information or just have questions, whether you're a current customer or you're just looking into CariFree for the first time, please visit one of the links that you see on your screen. We would be happy to help you. Anybody here can answer questions. We're all very knowledgeable, and we can definitely help you out. So thank you all, and I hope you have a great night.
Great to know, and everybody have a great evening. Happy first day of spring.